and welcome to the Calgary Neuropathy Association. I'm Linda Petiot, your host today, and the president of the Neuropathy Association. And also with us is Louise Jones Moore. I want to introduce to you Dr. Michael Kentris. He graduated his neurology residency from Wright State University in 2017, followed by a fellowship in clinical neurophysiology at Vanderbilt University Medical Center in 2018. He then returned as a faculty to Wright State University, and while there was active in neurology education for the residency program, and was given the Excellence in Teaching Award by the neurology residents for 2 years in a row. Congratulations. He has since moved to Youngstown, Ohio, where he continues to teach medical students and residents regularly, both in person and online. He also works with the American Academy of Neurology's Continuing Medical Education Journal, Continuum, as a narrator. Dr. Michael Kentris, I'm going to hand it over to you.
Thank you. I really appreciate the invitation to join today, and also thanks to both Linda and Louise for helping brainstorm some topics with me. It's always helpful to hear from people about what they think would be most valuable. So I really thought this was an interesting topic, the building a trusting relationship with your neurologist, which I think you can kind of almost extrapolate that to any kind of intimate, long-term relationship, whether that is professional or personal. But it made me reflect a little bit about, how do I, even myself as a physician, find physicians for my own healthcare that I trust, whose opinions that I respect. And I think that that's really challenging. There's so much that isn't publicly available. A lot of it's word of mouth. Finding people who had, a good experience with someone and kind of tracking that down. So I kind of was jotting down some ideas about things that I often do when I'm looking for a physician, more broadly speaking, and then we'll kind of talk about neurologists in particular, because I know they're a strange breed sometimes. But I think the easiest thing, is usually just a simple Google search and looking online, seeing what kind of reviews do you have out there. Now, I always think there's a grain of salt to that. You're going to get 3 bad things written for every good thing that happens. Or there's that one phrase, right? Success has 1,000 fathers, but failure has none, right? Same kind of idea, where you're not going to hear as many of the good things that people have done online. But looking to see, like, how much truth is there? Does it sound like someone just, venting their spleen, or does it sound like they have like very legitimate, concrete concerns about the care they received? And sometimes it's true. But the other things I usually look for is, if you're getting this referral from your family doctor or another specialist to a neurologist, very often they do have a working relationship, and asking them, like, what is the temperament for this kind of doctor? Is this someone that you yourself would go see if you had your choice of whom to see? I think that's usually a good thing. And one of the kind of backdoor ways I think that you can kind of figure this out is sometimes just calling the front office of the doctor's office and asking, like, do you work with Dr. Smith, pretty much every day? Would you see him as a patient? If the staff is unhappy, there's usually a good reason for that. So I do think that is an important thing to keep in mind, right? It starts at the top and works its way down. So you do want to make sure that, to use the younger generation slang, do a vibe check on the office and see how well off does everyone feel like they're doing there, right? If the office staff is happy, everyone who's coming through seems to be happy, that's usually a good sign of a good interaction in the future. And likewise,
do you really think they're gonna say, no, don't come see him, he's not very good? Do you know what I mean? Like, I could see them kind of just going, and there being a very long pause instead of, oh, he's great, like, I really, yeah.
Exactly. And I think you have to take that long pause. If there is a long pause, That's your answer, I'd say. But that would be my 2 cents. Again, whether or not you want to live or die by that kind of nonverbal communication, I think it's something to help prepare you. And I know, neurologists aren't the most plentiful specialist out there. I apologize for the siren. I'm at the hospital right now. Okay, good. But sometimes we're not spoiled for choice. I know in my area, there's only 3 or 4 neurologists, in about a 60-mile radius. So there's not a huge number to select from. And I know in some parts of the country, there might be 100 miles and you only have one. And I know there's lots of places across the world that are like that. So I think the other piece of that is finding out, is this neurologist someone who would be open to doing virtual visits as well? Now that adds in a little bit of a wrinkle, in particular for neuropathy and neuromuscular type complaints. But there are ways to get around that. A lot of times I think it's still good to do the first visit, even if you have to drive a ways, to get to that sub specialist, if that's who would be best for your care. But a lot of times, if you dig out, say, like a box of safety pins and get yourself a tuning fork online from Amazon for like 15-20 bucks, then you can, do a lot of the exam with the doctor virtually as well. Because that's a lot of what they're looking at. It's like, how is the sensation, looking at the strength, having someone there with you to participate in the exam. And there is a little bit of instruction that can go with that, but with enough advanced planning, I think telemedicine can still, for those people who are very far away from a neurologist who'd be best suited for them, can still make it work. So I think that's something to keep in mind also. Excuse me. But I think that's kind of the hard part, is like getting the advanced idea for the neurologist. And then something I might have skipped over a little bit in that Google search is like, what kind of training do they have? Neurologists go through typically 4 years of post medical school training, usually a year of internal medicine and then 3 years of neurology specifically. Some people will do an additional fellowship after that. So in particular, if you're someone who maybe has a more complicated case, you might want a neurophysiologist or a neuromuscular specialist. And these are people who are more trained about performance of EMGs and or different neuropathies or other neuromuscular disorders. And so they're going to have a wider knowledge base and maybe entertain some other treatment options that someone who's less comfortable may not. So I think knowing what the specialty, if they have one, beyond neurology of your physician is, can be very helpful for selecting someone, especially if there is like a practice group nearby. Maybe like this person does mostly like Parkinson's disease, this one does epilepsy, this one does more neuropathy. And so that might be the best person for you. There's always a balance between expertise and temperament, I think, though. So that is, a challenge sometimes. I remember I had a neuromuscular attending who, when he wasn't in the hospital, nicest guy in the world. But, something about the hospital environment just made him like stress out, and, he turned into an entirely different person. So sometimes the communication wasn't as good as it could have been. So I think that is an important piece as well. The best doctor in the world is not going to do you much good if every time you talk to them, you can't stand to listen to a word they're saying. So I do think there is a balance there. But that's kind of my thought process as far as seeing someone. And then I think another piece of that is sometimes you don't find this out till after you've seen them, is it kind of goes into that advocating for yourself piece of things. If you are wanting to try something or have certain testing done and they just shut it down without any real discussion as to why or why not, that's usually not a great sign. Like, we really want, to have a conversation about why we are or aren't doing something. And I think that for some problems that can really get into the weeds a little bit in terms of complexity. But for people who are really advocating for themselves, that's really what they want. They want to have that knowledge, because some people do find that extra information helpful from a kind of psychologic perspective, if you will. Knowing what something is. I know when Linda and I talked in the past, we talked about idiopathic neuropathy, which, depending on what study you look at, around 20-ish% of people with neuropathy might end up with idiopathic, which, as I say, when I'm talking with people, is just, a fancy word that says we're not sure why it's happening, but we've checked for a reasonable number of things. Now, what's reasonable for one person might not be reasonable for another. And, the research for different genes that are implicated in neuropathy, that list is growing every year. We're finding more and more causes of neuropathy out there. And so that's really challenging is, at what point do we say, even if we find a genetic abnormality, it may or may not change anything? Some people want to know. Some people, it doesn't matter as much to. So I think having that conversation, if, they've checked for the common things, right? Like diabetes, B12 deficiency, other kinds of abnormal blood work that can be implicated in neuropathy. And if that all has been normal, then that you sometimes get slapped with that idiopathic label. And I think that's the time to talk, is there stuff in the family background that might point in a certain direction? Do you want to, send off blood work for these different genetic panels that may or may not come back? I know it's different in the US probably, but one thing I always say is like, it can get a little pricey. Insurance doesn't often cover it. And so we're talking about, expenses. And
yeah, in Canada, I think what happens is there's a limited list of things that they will do, and I don't know that they even have that much control over going any further, which is why you probably see some Canadians come down to the States for additional testing and stuff like that. Yeah.
Right. And a lot of these labs, you can kind of order the blood work a la carte. You don't necessarily need a doctor to do it. That can get a little expensive. Usually we're talking in the neighborhood of like $1,000 to $2,000 thereabouts, which, it's not peanuts. But it really depends on if that information will be of benefit to you in your own decision making. And I will say, at some of these larger institutions, we are seeing research being done on different genetic causes of neuropathy. And while we don't have treatments for some of them now, I would not be surprised if 10 or 20 years from now that there are genetic treatments for some of these. We are seeing this in some pediatric diseases like spinal muscular atrophy, which is kind of a motor neuron disorder, right? For the last, oh gosh, I forget, it's been about 7 or 8 years, I want to say. They have gene therapy, which the expense for that, is sort of clocking around $1 million for a treatment. But we are seeing gene therapies being successfully researched and implemented with pretty impressive results for some patients. So I think that genetic testing is going to become more and more important. And what we might have chalked up to, oh, go ahead, Linda.
I'm just curious, do you see as those treatments have been around longer and longer that the prices may actually come down? Like maybe from $1 million to $500,000, not that helpful, but
Yeah.
you get my point.
Yes. And so typically once the patent expires, we often do see a drop in price, not always. One of the problems is that some of these are for a very small population of people. And so we don't have the benefit of scale that brings those prices down as much. So I think that is a challenge for a lot of neurologic disorders in general, is that when we start talking about some of these rarer things, or, like if we take Charcot-Marie tooth, right, there's dozens of different genetic variations. So what works for one person with CMT may not work for another person with CMT. Clinically, they might look very, very similar, but the underlying genetic cause is different. So the medication for one that might have been developed may not be effective for another. And so that's, we're really getting into I think we're coming into the era of designer drugs and things like that. And we're kind of more in the animal study phase of things for a lot of these, but I do think that there probably will be some evolution in that. You know, this last decade's been the decade of like the monoclonal antibody for a lot of autoimmune conditions and things like that. But I do think we're probably moving into like kind of genetic territory. I would not be surprised in the next 10 to 20 years if we are seeing some of these things having more custom built treatments in terms of like different manipulations of DNA and stuff like that, depending on like, are we expressing too much or too little of certain proteins that are leading to different clinical problems.
Sorry, I didn't mean to derail you.
That's okay. No, it's very very speculative at this point. I remember when I was a fellow reading, so this was 6 years ago, they were talking about a Charcot-Marie Tooth model of neuropathy in rats at that point in time, and you know, interesting stuff happening there, but very much not to the people stage of things. So, but it's very heartening that we are seeing advances. So I think that's very fascinating. And you know, when medical students are training in neurology, then one of the criticisms is like, oh, well, I don't want to be a neurologist. There's no treatments for anything. But I would say that you know, it's a field where it's so in evolution that, you know, we're going to be seeing things that were previously untreatable, developing treatments. And I think like multiple sclerosis would be like a classic example of that. You know, 30 years ago, it wasn't anything that really slowed it down. Now we've got dozens of options that can markedly improve quality of life. So I think that we're going to continue seeing that progression for other diseases as well, like different types of neuropathy. Should we take these chats, or do you want me to keep rambling? Oh, sorry, you're muted there, Linda.
Yeah, let's start with Lisa's. Give her
Okay.
attempted blood test for CMT twice in the last year or two. Both were removed by the Alberta Healthcare. After finding out only genetics or neurologists could order it. My last neuro refused. Genetics rejected me until a positive test. Then we had to restart yet another new neuro referral, which is about 10 months here. Unfortunately, it's come down. It was 18.
Yeah.
Oral blood tests have several ECGs done.
That ECGs or EMGs?
Probably EMGs.
Okay. Yeah. Huh. So it's interesting. So that is the tricky part. And without knowing some of the details, I will speculate if that's okay. That's okay. So without knowing the results of the EMGs, it does get a little hairy. So, but what I would say that if they're talking about the specific CMT1A or the PMP22 gene abnormality that we see with CMT, then if your EMG did not show the typical findings on that, then it probably would be of limited benefit for that specific genetic test. Now, there are, as we mentioned, other types of CMT genes that can have variable presentations and variable EMG findings. So some people do have what we call variable penetrance. That is, say, some people have more expression of an abnormal gene than others do. So it may not be as manifest either physically or on the nerve conduction studies. So it may be for that specific CMT test, but again, I'm speculating. That would be the only reasonable explanation I could think of, is that it doesn't look like the demyelinating variation of CMT for that specific gene test. Sorry, that's that would be my best guess, though. Let's see. Anne, baclofen helps, but I don't have muscle spasms, muscle tightness in upper thighs, pain and lack of balance. So yeah, I'll try not to get too into the weeds here. I know, but muscle tightness, it depends on the ultimate cause, is what I would say. So there are many different types of muscle relaxers. So muscle tightness, again, it depends. Is it because of a musculoskeletal issue? Is it because of a spinal cord issue, a brain issue, et cetera, et cetera? So it ultimately comes back to like, what is the underlying explanation?
Yeah. If somebody were to ask me stuff like that, I usually say, we'll start with the cheap stuff, right? Start with
Yes.
the
Yeah.
magnesium supplements. Make sure you get the
Mhm.
right one, because there's like 5 different kinds of magnesium.
Mhm.
A lot of people use pickle juice. That one I can't warm up to, but a lot
Yeah.
of people swear by it.
It helps
And
a lot for
then,
muscle cramps in particular.
oh, okay. Okay, sorry. I think I have CMT1A. Should I have a nerve conduction test? You probably won't get any benefit, I would guess. What do you think?
Yeah, I would agree with that. So, folks who have CMT1A, I remember one of my attendings when I was in training. He was older than I am, but he was talking about, so before they had genetic tests widely available, most of the people with CMT would be diagnosed in the EMG lab, on the nerve conductions. These days, we're seeing it much more where people are diagnosed from the blood test. And the main utility of having any nerve conduction tests or EMGs in that situation is if we see a sudden change in the pattern, right? If abruptly, say, an arm gets weak where it wasn't weak before, or you have new symptoms that don't fit the typical timeline of how your neuropathy has been evolving over time. So unless you're having new symptoms or worsening symptoms that don't fit the typical mold, it's probably of limited utility.
There's an interesting question. Has gene therapy been
Oh,
successfully applied? Yes, but you may have already answered that.
so yes, to so specifically to what we call motor, I guess more accurately called motor neuron disease. So that's spinal muscular atrophy. It's a genetic motor neuron disease, which is kind of like motor neuropathy. It's kind of a little hazy of a border there, but it's been used in pediatric populations specifically. It hasn't been shown to have as benefit in adult onset spinal muscular atrophy. So that's a bit of a fuzzy area. We don't have enough data yet really to say how old can people be who benefit. But in that population specifically, yes. So not a huge number of, obviously there's dozens and dozens, if not hundreds of causes of neuropathy, but in this one specific case, there has been. And as far as research goes, they're still kind of in the animal phase for other types of neuropathy. At least that's my current understanding.
Uh, Someone says she has great trouble walking. Is it because of peripheral neuropathy?
Mm. So that's always a good question. And it's actually a common reason that I'm asked to see people is for trouble with walking specifically. And so what I always like to say is if we think about what we need to walk in terms of all the processes, we're unique amongst many of the species by walking on 2 legs. And if we think of it as being in constant danger of falling, then we start to get an appreciation for all the systems that have to be working together for us to remain upright. So first of all, strength, right? We have to have enough strength in our legs to keep us upright. And then the other parts are all related to making sure that we are coordinating everything together. So the 3 main things I talk about are vision, our vestibular system, or our sense of balance, and our proprioception, or our sensation of where our joints are in space, in our feet in particular. Normally, people can accommodate for one of these being a little impaired. Maybe you have some numbness in your feet and you're doing fine, but maybe you find that if it's dark out or you can't see well, then you start tripping and stumbling more often, or maybe even have some falls. Similarly, for people who might have some inner ear dysfunction. So you can usually accommodate for a loss of one of those 3, but if you lose 2, that's when people start to run into trouble. So if you're also having some weakness as well as that sensory loss in your feet, that's where things start to get a little more challenging for a lot of people in terms of walking. But neuropathy is a very common cause of difficulty with walking, unfortunately.
Now, Dr. Kentris, an interesting question. this person, Rich, has recently been diagnosed with CMT1A by a gene test. He'd like to know if he should have his adult children get tested too. One of his sons has the stereotypically CMT1A feed.
Well, probably feet, I imagine.
Feet, I guess.
Yeah. Yeah. No, I've definitely seen, I remember specifically having, no, that's okay. I had a gentleman come in, he was in the hospital having some respiratory difficulties, and they asked us to see us for like muscular dystrophy. And so we go in and we're like looking at his feet, right? And he had the CMT feet, and then he had 3 generations of his family with him. And so I asked to see all their feet as well. So I looked at like a half dozen people's feet at the same time. But and you could see, like he was in his 80s, his kids were, in their like late 50s, and then their kids were in their like early 20s. And you could see the progression over time of the kind of the high arches and the hammer toes to some degree for some of them. And to your question, I would say it probably would be useful to have the genetic testing done. If he's a younger person in particular, that can sometimes be helpful, particularly if we're talking about if he hasn't set on a career, or if he is in more of a physically demanding career, maybe making plans for transitioning to another line of work that may not be as demanding. Again, depending on progression, that can sometimes limit what people might be able to do as an occupation and things like that. So if that is something that he knows he needs to watch out for, that can sometimes help him plan ahead, in the long term. And then maybe even with family planning, the joint pain as well, right? So like someone who's, oh, sorry, go ahead, Linda.
Oh, sorry, that was me. I just wanted to say, I'm assuming, Rich, that you're in Canada, possibly wrong, but what they'll do here is, so my dad got diagnosed and then asked me, and I got diagnosed. So they asked about my sons. They asked about symptoms, basically. Only one of my sons had the symptoms, the other one didn't, so only one of them was basically eligible for testing. If the other one were to develop symptoms, I'm sure that they could test him then, but until there's actual symptoms, they don't worry about it. And I've always heard down in the States that there's a case for not getting diagnosed if you're not having problems yet, because especially if you're looking to get insurance or change insurance or whatever, because if you're diagnosed with something that could disclude you from certain things. So if they're thinking about it, maybe get your insurance first before you go and get diagnosed.
No, that's a great point.
Sad state of affairs, but yeah.
In fact, full disclosure, I got a big disability insurance policy before I started getting my cholesterol and stuff like that checked. So definitely I'm on the same page as far as making sure that kind of element is in order, because it can be a bit of an albatross as far as insurance goes. Great question, though. Oops.
I'm trying to be polite, so if I start coughing, I won't disrupt you. But
that's okay.
I was going to say, why don't you go ahead with what you were going to talk to us about? I'm just going to read Mary's thing here and see.
Sure.
If
So
I
yeah, as one of the earlier questions kind of illustrated, having a physician who's willing to work with you is obviously very important. Otherwise you wind up getting a second opinion, which it's never wrong to get a second opinion if you desire one, but it's frustrating if you see someone and they, don't really help out in the first place. There hasn't been a first opinion. So that can be definitely frustrating. And I've definitely been the second or third opinion person before. And yeah, it's very frustrating, but I think trying to find out, and that is why I kind of do recommend perhaps some unorthodox methods of inquiry about the temperament of the physician you're being referred to beforehand. So I do think it is helpful to try and get a check on that. Like I'll be frank disclosure, right? I've known neurologists. I would never want to see them as a patient. God forbid. But I know other people who, I would send my mother to them. And it really is hard sometimes if you don't have that inside line to make that determination. So I think it really is important to exhaust those methods you have. And the other thing would be like, if you're able to find out like, what does Dr. So-and-so typically do for patients with neuropathy? Does he typically keep on with them for treatment and talking about options and things like that? Or does he cut them loose after they have an EMG? And kind of finding out, like, is it worth your time to go through all the rigmarole? And, like, we've all had EMGs done, I assume, on this call. They are not particularly pleasant. It's not the worst thing in the world, but it's not great. So I do think it's important to try and, again, get a little bit more of a sense of what is likely this doctor going to do for me? What benefit can I actually get from this? And then also thinking about, something, again, Linda and I have talked about in the past is when we talk about treatments, a lot of neuropathies don't have a specific treatment per se, but we're really talking about symptom management, whether that's with medications or other types of things. Are they open to kind of complementary or alternative modes of treatment? A lot of times I'll work with physical therapists and we'll, train people on how to use like a TENS unit, the stimulator units, or, I've tried some medications that don't necessarily have a definite indication, but I have found helpful, like low dose naltrexone and things like that, which are a little unconventional. There is some literature to support it. I don't, prescribe willy-nilly, but I have found it helpful for some different pain syndromes and things like that. And then kind of talking about, I know a lot of people are using different types of supplements or herbal things like kratom is very popular these days. So I think having a frank conversation about like what are the risks and benefits of these things is important, as opposed to just blanket saying no. And I will say like I'm not a fan of kratom, just given all the side effects that I see, but I know that it does help some people out there, just as an example. The other piece I like to mention as far as like testing and things like that, I kind of glossed over a little bit earlier. Like having an EMG done. In my own experience, I see a lot of EMGs done around, the area, both where I am locally and where I've been in the past. And a lot of people don't interpret them very well. So there is a subjective quality to EMGs and nerve conduction studies. The EMG, the needle part, more so than the nerve conduction portion. And I've had referrals from people who have given me bizarre reports in the past. And when the patient shows up on my doorstep in the office, I'm like, well, you don't really have any of the symptoms that this person's saying that you have this disease, like a myopathy or, some muscle disorder. And so you do want to have one done by someone who is, I would say, usually a neurophysiologist or a neuromuscular specialist, generally speaking, because they're generally going to be more competent at it. Again, in my opinion, there are some general neurologists who do a lot of EMGs in their training, but it is a little bit more uncertain as far as that piece goes. But looks like we got some more questions popping up. Did you want me to take any of those, Linda?
Yes, please.
Okay.
So the first one was, I have CMTX1 and it runs in my family. What signs should so you see that my sisters to look for if they suspect their kids have CMT?
So in kids, it can be a little different depending on the age. When we're talking about very young children, generally it's thought to be more of like decreased muscle tone that they sometimes unflatteringly refer to as a quote floppy baby. So you are looking for the way that a child neurologist would assess for something like this is if you are holding a newborn under the arms, or, a few months old at least, and they generally have enough muscle tone under their arms that they kind of stay on your hands. Whereas a baby with like a bad neuropathy or a myopathy will slide. Don't do this over open heights, but they'll slide through your hands. So you have to make sure you're ready to catch them. But generally they have reduced muscle tone. And so that's one of the signs to look out for, or knowing what the milestones are for children, like in terms of being able to grasp things, being able to grasp things. When do they stand up? When do they roll over? And if we see these delays in these milestones in development, that may be suggestive of something from a genetic cause as well. So you kind of have to, just as long as you're staying in close touch with the pediatrician and they're keeping track of these milestones, generally that's the first sign that most people will notice if it's not a severe form.
Right. There's many of us who really don't get diagnosed until much later. My dad was 77.
Right.
And ergo, I was in my 50s, right? So
yeah, I know a lot of people, they just think they're kind of clumsy or, uncoordinated. They just weren't as fast running with the kids on the playground, all that kind of
Yep.
stuff, that it
Yep.
never rose to that level of impacting them to the point where they, weren't able to do most of the things they wanted to do. But then as we get older, we start getting arthritis maybe at a little faster rate, or the neuropathy progresses and we notice maybe ankle weakness or more trips and falls and things like that. So unfortunately, it just varies a lot family to family and person to person within that family.
There's a question here from Ann Russell. She says she was told that CMT causes muscle tightness when some nerve endings stop working. So roll out muscles with physio stick, add heat. But she's very confused about this treatment. Her pain is in the groin.
Okay. So yeah, so pain with CMT can be tricky because there's kind of the two components, right? There's the part where some people have like the nerve related pain, and then if they have weakness, that can sometimes lead to musculoskeletal pain, so joint and muscle pain on top of it. So ultimately, it kind of depends on what type of pain we're really talking about, or what the underlying cause for this is. Some people might notice, like, for instance, groin pain. If they have weakness, I keep talking with my hands, you'll have to forgive me, but people have weakness in their hip flexors. And so sometimes that can refer to the groin because maybe they've changed the way that they walk. Maybe if they have a little bit of foot drop, they're lifting their knees higher, and that's putting more strain on the hip and the low back, and that can cause some referred pain to the groin. Again, right, I'm wildly speculating with just two sentences there, but that's one potential way things like that can happen. So it is important to take kind of a whole person approach in terms of the biomechanics of what's going on, because it's not just the CMT that could cause pain, but also the way that you move around on a day-to-day basis because of it, that can also result in pain.
Right. I know I've been told a couple of times that people with the tight muscles, whether it's from CMT or something else, it's not necessarily a good thing to roll them out because you're putting pressure onto the nerves in there and potentially causing more damage. I think maybe the small fiber nerves is more the concern. They're close to the skin, and I'm always kind of waffling on whether that's a good thing or not, because it does feel good, but I don't want to cause more damage, for example.
Yeah, I would say as long as you're not going overboard, the risk is probably fairly minimal. I would say I'd be more worried about excessive heat and ice use. Generally, like 30-minute blocks would be kind of the most you would want to do, as you could cause some injury to the skin, from leaving something too hot or too cold on there for too long. But generally, if you're using heat or ice, especially if you do have neuropathy, I would say first touch it to an area of your body that doesn't have neuropathy. Make sure it's not burning your skin in the area that's not affected. Because if it's burning the skin, like say on your shoulder, then you probably shouldn't be putting it on your feet, because you can't protect your feet. You don't have that protective reflex from pain. And so I would say in that situation, yeah, you could probably cause some damage to your skin.
Dr. Kentris, there's a very long question from Mary, which starts with, I have normal looking feet. Do you see that in the...
Yes. Uses exercise equipment. Can't bend feet upwards. Microfiber AFOs. So yeah, if anyone is having a foot drop or things like that, I think an AFO or ankle foot orthotic is usually a good option to consider. It's, you know, kind of I would say the standard to start with. And there's a whole bunch of variations within that in terms of how complicated and how much mechanization they have to them. Like even in some of I had a patient once who got, she had a nerve injury from an accident and had one of the stimulators placed like a skin, kind of like a TENS pad unit, and it would basically cause the muscle to fire when she was walking. So kind of like an electrical assist stim. So kind of like an electrical AFO almost. Kind of an interesting device. But I've only had one patient with that. They tend to
I've
be,
never seen or heard of that before.
they're a little tricky to get, and you have to get trained on them. So they're not for everybody. It does depend on the cause of the foot drop, but for some people where the muscle is intact still, it can be an option to help with a little bit more ergonomic gait.
And what do you think of ketamine? Very good question.
So ketamine, yeah, it's definitely having a moment the last couple of years.
Yes.
But I think that there is a lot of benefit for it for different pain-related conditions. I would say you have to watch out for, again, who is the one administering it. So if I was going to be, so if me, hypothetically, if I needed ketamine for, like, say, complex regional pain syndrome or some sort of painful neuropathy or something like that, I would probably be wanting to seek out a pain specialist who also does ketamine, because you do see a lot of people like in anesthesia or, you know, other fields that don't directly work with chronic pain who are doing these ketamine, like they used to these little pop-up ketamine clinics places. And so you really want to be part of an integrated treatment plan and not just kind of going for that treatment.
Makes sense.
There are some interesting, on that same vein, some interesting studies potentially coming out, like with different like psilocybins and things like that. Not prime time yet, but it wouldn't surprise me if another 2 to 5 years we start seeing some data about those types of things as well.
You're talking about mushrooms, right?
Yes, the magic mushrooms.
So I want to sign up for that one. I want to try that.
And what are your thoughts on naltrexone? Am I pronouncing that correctly? NALT.
Yeah. So
Someone here says that it's successful.
Yes, I have prescribed low dose naltrexone, right? People are probably more familiar with it as a medication that's sometimes used for alcoholics or people with opioid use disorders, things like that. And it's kind of interesting. So it has at least, you know, theoretically in some of the studies, kind of a paradoxical response. So at high doses, it blocks these mu receptors, these opioid receptors, right? So we have endogenous opioids that we make in our bodies. So at high doses, it blocks it. Usually, I think the dose, and you know, I might be off on this, I think it's around 50 milligrams is kind of the overdose dose. And we're typically using 1 to 5 milligrams, as David said here, usually 1 to 5 milligrams once a day. And I've used this for a number of different syndromes. I've used it for peripheral neuropathy, for chronic fatigue syndrome, for fibromyalgia, with mixed results, I would say. Some people have gotten huge benefits from it. Other people, not really anything at all. What I would say is it's generally considered pretty low risk at that dose, right? It's about 1/10 of the dose that's used for the prescriptions for more typical overdoses. So I would say it's not for someone, obviously, who is on chronic opioids or narcotics, because it's going to kind of be two things fighting against each other. But it's thought at those lower doses that it might enhance that endogenous opioid effect and kind of enhance your kind of, again, your endogenous receptors. That's the theory, at least.
And I would like to know the answer to this question. What about CBD oil?
Yeah. Sorry, just grabbing a drink of water here. So for CBD, I I think it's fine. And I think it does have, again, when we talk about just chronic pain in general, not necessarily neuropathic pain, but like low back pain, headaches, things like that, there is some data that would suggest that it is helpful for neuropathic pain and things like that. It's not super robust data, but my opinion on CBD specifically is that you need to just make sure that it's not going to interact with any other medications that you are on, because it is metabolized when you're taking oral CBD. About 90 to 95% of it is metabolized in the liver first pass. So only a small percentage of what you're taking is actually making it into your system. So for instance, there is a prescription CBD oil, Epidiolex, that we use for epilepsy. And it has lots of interactions. It's at much, much higher doses than what you can get from like a dispensary or things like that. So I think CBD is fine. Again, as long as it's not interacting with other medications. And you do have to keep in mind, right, that it can adversely affect sleep in some people also. So if you are having cognitive difficulties, if your sleep is impaired and you're using CBD, or I find this more often with marijuana specifically, you might need to cut that back to see, kind of doing a little medication vacation, if you will, to see if that is a confounding factor for you specifically.
Yes, I know that my CBD MD, it's legal here, all of this stuff,
Right.
even with
Yes,
trace
I should
amounts of
say, as long as it's
THC.
legal where you are, of course.
Yes, but he did say, unfortunately, that it increases cholesterol levels, and that makes
Yes.
sense if the liver has to. It's
Yes.
very unfortunate. Now, something that I've noticed with my new, they're called licensed producers of cannabis for CBD oil. Canna Farms, they have a subvariant. They have 3 subvariants of CBD, so 3 different strains, one of which is for muscle pain. It's interesting.
Yeah. I don't know oh, go ahead, Linda.
Oh, no, I was going to change the topic, but yeah.
Oh, okay.
That's
I was just going to say, I
there's
don't
so
know
many
that.
strains here and stuff.
Yeah, I know that they do
Oh.
try and get into those variants, and sometimes they'll have a little bit more of different subtypes like Delta 9 versus Delta 11 or Delta 7 and things like that. It's a little bit beyond my knowledge base, so I'm afraid I can't give any good recommendations as far as that goes.
I wanted to ask about, we've been talking a lot about the muscles being impacted, and what you said, it was very interesting about the 3 things, and if 2 are impacted, you got more of a problem than if it's only 1.
Yes.
So what about, I know a lot of people use or try creatine, I think it's called, to help build muscle. Is that something that's really advisable to, not that I'm going to go try weightlifting or anything, but
Yeah.
Actually, I shouldn't say that because I do that.
Well, yeah, nothing wrong with that specifically. Creatine, it's taking me back to my college days where I would go to the gym more regularly myself. Not that I took it. I was never able to put on a lot of mass. But that's what creatine typically does, is it provides a substrate for muscle bulk. So it doesn't, again, there might be someone out there who would disagree with me, but in my experience, limited though it may be, it's usually more for increasing bulk more than strength specifically.
Oh. So not really what I would be looking for.
It's more for looking good at the beach than
Okay.
than lifting heavy things.
Okay, so I don't care much about that, but
Yeah, and I would say that's also a good point, is that it does matter what the etiology of the muscle loss is. We're talking about, say, someone who was laid up in bed with a nasty infection for 2 weeks, who is weak after that, versus someone who is having nerve damage where the nerves just aren't connecting to the muscles as well. And I do think, to your point, lifting weights and regular exercise is good for preserving those intact motor units, or I should say, making those intact motor units able to lift as much as possible. So that way you can preserve as much strength as possible. But it's not necessarily going to bring back. And you might get some hypertrophy, some enlargement of those muscles over time. But yeah, I mean, there's tons of exercise websites out there. T Nation, I think, was a big one back in the day for the gym bros. But yeah, I don't know that a lot of that stuff's more focused on the bodybuilding community, more so than like functional strength. Although I'm sure that there's some protocols out there that talk about how you could properly incorporate it into to that, but I don't know that it's something that's been studied robustly.
No, I was actually thinking I thought it was for building muscle strength. And if it's just for bulk, it's of no use to actually solve the problem, I guess, or improve the state.
Yeah.
So.
But in and of itself, if you need more protein in your diet, it's not a bad option. I will say that.
Okay. How about weightlifting? Kathy's asking.
So yeah, I think weightlifting is great. There's a lot of different ways to kind of skin that cat, if you will. But the general recommendation for folks who have neuropathy is that you want to lift as much as you are able to safely do. And what I mean by that is we always talk about this with exercise in general, is form. Form is the most important thing to prevent injury. So you should be lifting things that are heavy to the point where you're kind of wobbly or unsteady, or you're not able to maintain a nice smooth movement through the range of motion. So in that situation, weightlifting, you probably need to back it down, but I would say, as long as you're not compromising joint stability or putting yourself at risk of injuring other parts of your body, that's really the main thing that you have to watch out for.
And how do we get our functional strength back?
So that is a tough question, and it's going to be different for everybody. Again, depending on what the cause is, whether it's something that has a treatment, doesn't have a treatment. Sometimes we're talking more about slowing decline rather than reversing decline.
Definitely.
And I know that's a hard conversation to have, but sometimes once nerve injury has happened, there isn't a huge amount to reverse it, again, depending on the cause. And so we're really focused on slowing progression and maintaining what functional strength there is. And a lot of that is a combination of aerobics. It's a general whole healthy lifestyle, right? Like, well-balanced diet, good sleep, a reasonable amount of exercise, whether that's aerobic, lifting, things like that. So a combination of those things is really going to be most important.
Okay, so I just want to do a time check with you because we only have about 2 minutes left.
Okay.
Like if you want to cut off right at 2 o'clock. I don't know if you have other stuff that you have to get to. I'm sure you do.
Entirely up to you.
Well, we could probably go all afternoon, so.
Oh.
But I won't do that to you. Oh, there you go.
Thank you. Thank you. Sorry about that.
That's okay. But yeah, functional strength. I know some of our folks, they have very, very little strength left. And so there was a lady out in Ontario, she basically had trouble getting even up off the couch.
Right.
So
right.
I would suggest, not that I'm any kind of expert, but really working it slow, getting a professional, like an athletic therapist, a physiotherapist, whatever kind of therapist will help you to make sure you're doing it right. Even a personal trainer. I mean, there's degrees of cost there. So personal trainer is probably, actually an athletic therapist is probably the cheapest one, in my experience anyway.
And especially if we're talking about, I would agree 100%, someone who has a medical condition that is leading to that. At least in the US, I know that athletic trainers, they kind of get a certificate and they may or may not have a huge amount of medical knowledge, but they're generally focused on otherwise healthy people.
Mm-hmm.
But I would say, a specialized physiotherapist is probably your best bet, especially for learning how to do things safely. And then you can kind of build a plan and execute that at home at your own speed.
Yeah. Yeah. I know I like my physiotherapist. Is dark chocolate bad for you?
Would say it depends on what you mean by bad. Generally speaking, it's thought to be pretty okay. I know that this is anecdotally, I learned this from someone. There's been some cases of dark chocolate having elevated levels of, I think, cadmium recently. I forget what brands they were, but there was a report out about that sometime this last year.
I remember
So,
that.
so that is out there. What does that mean clinically? I don't know, is the short answer. I will tell you, I continue to eat dark chocolate with abandon.
Me too.
I've
Well,
only got so many pleasures in life, so
I try not to eat it with abandon, but I do still eat it
yes.
at
It
least
depends
once a
on how
day.
stressed out I am that day.
Yeah, yeah. Um, well, if anybody else, you better hurry up. There we go. Doesn't stem
Uh,
from alcoholism, but is it okay to have occasional drink?
so my general recommendation is 1 to 2 alcoholic beverages in a 24-hour period is kind of the upper limit. And what I mean by that usually is like a typical like 8-ounce beer, 4-ounce pour of wine, or a 1-ounce serving of liquor are all equivalent. So I would say alcohol, is poison. I enjoy a nice cocktail as well, but it is something that we do have to be cognizant. If it's a once in a while thing, probably not going to do yourself too much harm. If it is an everyday thing and you're someone who might be at risk of causing neuropathy from alcohol, then you probably need to be a little careful. And that's even if it's like, say, like a diabetic neuropathy or maybe a B12 deficiency neuropathy. If you've had nerve injury, then you're going to be more susceptible to further nerve injury. It's kind of once that rock is rolling down the hill, it just able to add speed to it. It's a lot harder to slow it down.
That's right. That's what we tell people. And it's again about slowing progression, right?
Right.
I myself have chosen now, much to my dismay, to stop alcohol because I just hurt too much when I do. My whole
Right.
nervous system, I can feel it. I used to be able to get away with it. I can't anymore. So
Yeah.
it sort of
No.
depends on where you're at. But every time you have a drink, you're risking just that little tiny bit more damage. So that's why I
Yeah.
needed to stop.
It
Same
is
with
one of those things.
sugar.
So yes, I would say, it's for anyone who's, I know about, 1 to 2 out of 3 of us are probably obese, overweight. I technically am overweight myself. And even if you are not diabetic, you can develop glucose intolerance, which is to say your blood sugar spikes up intermittently, but it doesn't stay up. And so that can, in some people who are susceptible, cause nerve damage also. So I would say that it is good to avoid what we call high glycemic index foods. That is to say, you eat something and your body turns it into sugar in your blood really fast. Like a classic example would be bread. Whereas, say, something like, a hamburger patty, that's like mostly protein and fat, your body takes a lot longer to break that down. It's going to make your blood sugar go up much slower. So things that have, and this is usually something you can look up online, is like, what is the glycemic index of the food that I'm eating? And if you are overweight and you find, I've had folks with diabetic neuropathy, terrible pain, and they lose 20, 30 pounds. They get their hemoglobin A1C, from a 10 down to like a 7 over 6 months. They come off the gabapentin, the pain goes away. That's not everybody, but it certainly is a big factor for a lot of people, that to get it to a manageable level.
Now, do you do consults?
So I'm only practicing in Ohio. So if you're in Ohio, you can track me down. I'm in Youngstown.
I will take that as a no, can't really do. We did have a question about what is ketamine, and I was going to do it in the chat box, but I think I'd rather just let you explain what ketamine is.
Sure. So ketamine is an anesthetic agent, in the same kind of God, I almost said in the same vein, no pun intended, as things like Versed or propofol, things that you might give to someone who is undergoing surgery. It is that, and that's what traditionally it would be used for. Like, for instance, if you go into emergency and you have like a dislocated shoulder, they might give you a dose of ketamine before they reduce your shoulder, because that's going to hurt like a son of a gun. But how it works is essentially I'm going to get into the weeds for a second here. It binds to the glutamate receptors in your brain. So glutamate is our main activating signal in the brain. So it's typically saying go, 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 as opposed to, say, like GABA, no relation to gabapentin, just a bad name. GABA is our main brakes in our brain. And so essentially we are blocking the go signal for a period of time. It wears off pretty quickly after a dose of ketamine, usually within like less than an hour for most people. But it has been shown to cause some like dissociation, which in people who are in chronic pain, they sometimes become too engrossed, and I'm oversimplifying to a large extent, so forgive me. But essentially, you become too locked in to your perception of your body, your perception of self as a painful entity. And so it causes some degree of dissociation, and that dissociation can help give you some distance from that feeling of being an embodied person in pain. At least that's
like
one of
kind
the
of like
theories.
obsession, right? I know I've talked to a few people who,
Yeah,
it's almost like they're obsessed with it and they can't think about anything else,
right.
because they feel like they're in so much pain.
Exactly. And one of the things we do know is that chronic pain, even if it is like in your arms or your legs, it feeds back, right? It goes back to your brain, and over time it does cause changes in the way that our brains work. And so the idea is to, instead of tackling the pain down where it's happening in the arm or the leg, we try and tackle it centrally. So that's what we call centralization of pain, essentially. And we can see that with a bunch of different disorders.
Right.
Dr. Kentris, can you define alcoholic neuropathy, please?
So generally, it's kind of what's written on the tin. It is nerve damage that tends to occur over time in someone who drinks too much alcohol. And you can certainly debate about what too much is, but generally speaking, if it's someone who has a habit of binge drinking or is consistently drinking more than 1 to 2 servings of alcohol per day, they're going to be at risk for it.
Especially, can you have nerve pain in your skull, forehead?
Well, that's an easy one. Yes.
No.
You can have nerve pain anywhere,
And your
unfortunately.
face. And yeah, I've had it in places I don't even want to talk about.
Yeah, absolutely.
Okay. Well, now I'm sure you have to get back to work. Thank you so much, Dr. Kendris. It was wonderful to
It
see
was
you
my
again.
pleasure. Yes, you as well. Thank you so much for inviting me.
Thank you.
Thank you, everyone, for your attention. Appreciate the questions. Hope everyone gets the help they need out there, and best of luck.
Yeah, thank you.